Hello and welcome. In this module on Buruli ulcer, we will review the etiology, epidemiology, and transmission of this disease. We will then discuss the clinical presentations of and available diagnostics for Buruli ulcer. Finally, we will explain treatment options and preventative strategies. First, let us contemplate some questions on this subject. We will return to these questions at the end of the module to see how much knowledge you have gained. Question number 1. What organism causes Buruli ulcer? Question number 2. In which areas of the world is Buruli ulcer endemic? Question 3. What are the more accepted theories about transmission of Buruli ulcer? Question 4. What are the causative agents' microbiologic characteristics? Question 5. What are the histopathological stages of Buruli ulcer? Question 6. What is the incubation period of Buruli ulcer? Question 7. Which stage is characterized by the following description? Large area of marked induration and diffuse edema in the arms that involves the entire limb. Question 8. What are the clinical criteria for the diagnosis of Buruli ulcer? Question 9. What is or are the most sensitive and specific laboratory diagnostic method or methods used to diagnose Buruli ulcer? Question 10. What are the WHO recommendations regarding antibiotic therapy for Buruli ulcer? Let's go on to the etiology. Mycobacterium ulcerans is a non-tuberculous mycobacterium, or NTM, and the main causative agent of Buruli ulcer. Despite being characterized as an environmental pathogen, M. ulcerans rarely has been successfully cultured from environmental samples. Like other members of the Mycobacterium species, M. ulcerans shows acid-fast qualities, has a fastidious pattern on culture media, and can only be cultured from samples obtained from human lesions on mycobacterial medium at 30 to 32 degrees Celsius after a 5 to 8 week incubation period. The infection results in an ulcer with a necrotic base. Under the microscope, the ulcer is full of extracellular acid-fast organisms and a few inflammatory cells. M. ulcerans is currently the third most common mycobacterial pathogen in humans and animals. It was first defined by McCallum in 1948 in the small city of Bairnsdale in Victoria, Australia. Prior to the 1980s, Buruli ulcer was found mostly in several countries in sub-Saharan Africa, including Congo, Uganda, Gabon, Nigeria, Cameroon, and Ghana. M. ulcerans was first named, quote, Buruli ulcer because the first described case was in Buruli County, near Lake Kyoga in Uganda. There are, however, an assortment of names by which the disease is known, including Bairnsdale ulcer, Daintree ulcer, Mossman ulcer, and Searle ulcer. Since the 1980s, a dramatic increase in the incidence of Buruli ulcer has been reported in the West African countries of Benin, Ghana, and the Ivory Coast. Recently, new focuses have been discovered in Togo and Angola. Among these countries, Benin, Ivory Coast, and Ghana are the main focuses. Studies have shown that in West Africa, approximately 25% of the people are affected by Buruli ulcer. According to the WHO, there were 4,888 new Buruli ulcer cases reported in 2010, primarily in children under 15 years. However, it is estimated that the precise incidence of Buruli ulcer is higher than the WHO report. Epidemiologic studies have indicated that Buruli ulcer occurs at different frequencies in one focus compared to another. For instance, some highly endemic districts in Ghana have a point prevalence of 150 per 100,000. In Benin, prevalence can be as high as 22 per 100,000 per year. This regional difference makes it more difficult to estimate the precise global burden of Buruli ulcer. Buruli ulcer is a poorly understood disease that has emerged dramatically in the 1980s. M. ulcerans is found in communities associated with rivers, swamps, wetlands, and human-linked changes in the aquatic environment, particularly those created as a result of environmental disturbance, such as deforestation, dam construction, and agriculture. Many studies support the connection between the incidence of Buruli ulcer, water resources, and in most cases, children between the ages of 4 and 15 years. A case control study in three endemic countries in Africa found that swimming in slow-flowing rivers or shallow ponds is an independent risk factor in contracting Buruli ulcer with an odds ratio of 2.69. The same study reports that wearing long-sleeve shirt while farming, sharing indoor living space with livestock, and bathing with soap can be protective. A recent review by Jacobson concluded that poor wound care, failure to wear protective clothing, and living or working near bodies of water are commonly identified risk factors. Although Buruli ulcer is linked to contact with contaminated water, there are different theories to explain its mode of transmission. Recent evidence suggests that water insects, including Nacoris and Diplonicus species, can be involved in the transmission of Buruli ulcer. However, lack of evidence regarding insect-to-human transmission and controversial reports about the insect's role in West Africa has brought the theory's legitimacy into question. Another theory postulates transmission through skin trauma. The histopathology of Buruli ulcer can be classified into 4 stages. First stage is non-ulcerated necrosis. Second stage is ulcerated necrosis. Third stage is initial healing. And the fourth stage is late healing. Let's begin with the first stage, non-ulcerated necrosis. The epidermis remains intact, but is usually hyperplastic, while the upper dermis is preserved. Coagulation necrosis in the lower part of the dermis, subcutaneous tissue, and fascia is noticeable. Predominant formation of extracellular bar-shaped clusters, bar representing extracellular acid-alcohol-resistant bacilli, in the center of the necrotic lesions, as shown in image C, is a histopathologic finding of this stage. Denucleated adipose tissue, or ghost cells, as seen in image A, is also a common finding. Stage 2 is ulcerated necrosis. Loss of the epidermis layer, as seen in image B, and re-epithelialization on the border of the ulcer are significant findings at this stage. Other prominent histologic findings are the formation of numerous bar-shaped clusters, extensive necrosis of the collagen, and exposure of the dermis with fibrosis, as well as formation of ghost cells, vasculitis, and inflammatory changes. Stage 3 is initial healing. This stage is characterized by formation of granulomatous tissue in the dermis and subcutaneous cellular tissue. Epithelioid cells, Langerhans cells, and lymphocytes are present during this stage, and they eventually reorganize to form tuberculoid granulomas. Stage 4 is late healing. This stage is characterized by the formation of granulation tissue, followed by fibrosis and a depressed scar. Buruli ulcer has a spectrum of clinical forms due to the gap between the time of onset, diagnosis, and treatment. Following initial contact, healthy individuals may develop an asymptomatic colonization of the bacteria. The disease may become subclinical and remain latent. Eventually, the latent disease will become active and the patient will manifest a full representation of Buruli ulcer. Sometimes a simple superficial trauma could activate the latent disease. After the primary infection, Buruli ulcer can remain localized or disseminate. Many factors, including host defense status, extension of bacteria inoculation, and strain virulence, contribute to the evolution of disease. The clinical course of Buruli ulcer can be divided into pre-, non-ulcerative, and ulcerative stages. The non-ulcerative stage is further classified into papule, nodule, and edematous forms. A papule is a painless, raised skin lesion less than 1 centimeter. It is usually accompanied by erythema of the surrounding skin. This form has not been reported in Africa. The nodule is a lesion that extends into the subcutaneous tissue that is usually 1 to 2 centimeters in diameter, painless, and mobile. This form is commonly seen in Africa. The plaque is a raised, firm, well-demarcated, depigmented skin lesion. These plaques are between 2 to 15 centimeters in diameter and can develop into large ulcers with irregular borders. The edematous form are areas of extensive, firm, painless, well-demarcated, non-pitting edema that involve affected areas. The nodular form eventually breaks down centrally after days to weeks and forms an ulcer with undermined edges. This progressively erosive ulcer is characteristically painless and is usually accompanied with edema in the adjacent skin. The ulcers vary in size. Some remain small at 1 to 2 centimeters in diameter and are usually self-limited. However, most of these ulcers grow to become large and destructive lesions. At the final stage, ulcers have undermined edges and necrotic bases, which may show cotton wool appearances. The undermined margins may cloak the real expansion of the ulcer as pictured above. Due to the immunosuppressive properties of the toxin of M. ulcerans, known as mycolactone, or due to other unknown etiologies, the ulcer characteristically evolves without pain, fever, or systemic inflammatory response. Common complications of Buruli ulcer are osteomyelitis, reactive osteitis, contracture deformity of the limbs, and amputation. Rare complications include secondary infection, bleeding, nerve damage, and sometimes blindness. In an endemic area, the diagnosis of Buruli ulcer is mainly based on clinical findings. Higher clinical suspicion of Buruli ulcer occurs when patients are younger than 15 years old, living in or traveling to endemic areas, and have presence of chronic lesions anywhere from weeks to months, 1 or more poorly demarcated chronic ulcers with undermined edges, absence of fever or regional lymphadenopathy, and edema over the involved joint, which indicates bone involvement. Due to lack of resources and operational difficulties, laboratory tests are not commonly used to make the diagnosis. The following microbiological confirmation is necessary to confirm the diagnosis and to provide crucial microbiologic and epidemiologic information about Buruli ulcer. The first is direct smear examination, or DSE. A direct exam is conducted on suspected Buruli ulcer samples, swab, or biopsy. DSE is conducted through acid-fast staining, or Zeil-Nielsen stain, and by using a TB microscope. Under the highest clinical suspicion, such as when the patient lives in an endemic area, this test is only 40 to 43% sensitive. The positivity of the DSE depends on the stages of the ulcer. In the nodular form, the positivity may reach 60%. In the edematous form, it may exceed 80%. The second is culture. Swabs obtained from the ulcers cultured on Lowenstein-Jensen medium take 6 to 8 weeks to grow. Sensitivity ranges from 20 to 60%. Polymerase chain reaction, or PCR, is the third test. PCR can yield results within 2 days of sampling. Its sensitivity reaches 98 to 100%. New, refined methods of PCR target both DNA and RNA and decrease the chances of false positivity due to contamination. PCR has the highest overall sensitivity. Culture has a sensitivity of 5% in the same study. PCR proved to be the best confirmatory test in untreated, non-ulcerative, and ulcerative forms. While disease duration has no effect on PCR results, previous therapy greatly reduces PCR performance. The fourth is histopathology. Among traditional laboratory tests, histology has the greatest sensitivity of 90%, but low specificity. The fifth and final method is fine needle aspiration, or FNA. This method is particularly useful during the nodular stage of Buruli ulcer and allows for the collection of the material for later tests, such as PCR or DSE. Buruli ulcers smaller than 1 to 2 centimeters are more likely to spontaneously resolve. However, without treatment, most cases of Buruli ulcer result in physical deformities that affect the patient's social, psychological, and physical performance. According to the WHO, current recommendations for treatment consist of a combination of rifampin and one immunoglycoside, streptomycin or amikacin, for 8 weeks as first-line treatment for all forms of active disease. The recommended dose of rifampin is 10 mg per kg PO daily for 8 weeks, and for streptomycin, 15 mg per kg IM daily for 8 weeks. If streptomycin is contraindicated, as in pregnant women, amikacin can serve as a replacement at 15 mg per kg IM daily for 8 weeks. Surgery is necessary to remove necrotic tissue and establish scars. It is used to correct skin defects and contractures, and also for cosmetic purposes. In many resource-limited countries where the disease is endemic, the cost of surgery is beyond what is affordable. The 90-day post-operative hospital stay further aggravates the situation. Prompt and proper antibiotic therapy has been proven to be a dependable, cheap alternative to lower the cost and limit the complications of Buruli ulcer. Our limited knowledge about M. ulcerans transmission and pathogenicity, combined with our lack of an effective vaccine, currently puts prevention out of our grasp. A randomized controlled trial in Benin found that the BCG vaccination does not prevent Buruli ulcer incidence in the vaccinated group, with vaccine effectiveness after being adjusted for socioeconomic status equal to 12%. We have now reached the end of the module on Buruli ulcer. Let's go back over the questions from the beginning of the module. Question number 1. What organism causes Buruli ulcer? The answer is Mycobacterium ulcerans. Question 2. In which areas of the world is Buruli ulcer endemic? The answer is Sub-Saharan Africa, including Congo, Uganda, Gabon, Nigeria, Cameroon, and Ghana, in addition to Australia and Eastern Asia. Question 3. What are the most accepted theories about transmission of Buruli ulcer? The answer is not clear, although theories centering on aquatic insects and direct skin trauma in polluted environments are highly accepted. Question 4. What are the causative agent's microbiologic characteristics? The answer is that M. ulcerans is a fastidious and slow-growing organism that can be cultured from human lesions on mycobacterial medium at 30 to 32 degrees Celsius. Question 5. What are the histopathological stages of Buruli ulcer? The answer is non-ulcerated necrosis, ulcerated necrosis, initial healing, and late healing. Question 6. What is the incubation period of the disease? The answer is 7 days. Question 7. Which stage is characterized by the following description? Large area of marked induration and diffuse edema in the arms that involves the entire limb. The answer is the edematous stage. What are the clinical criteria for the diagnosis of Buruli ulcer? The answer: patients younger than 15 years old, living in or traveling to endemic areas, presence of chronic lesions, weeks to months, one or more poorly demarcated chronic ulcers with undermined edges, absence of fever or regional lymphadenopathy, edema over the involved joint, which indicates bone involvement. Question 9. What is or are the most sensitive and specific laboratory diagnostic method or methods used to diagnose Buruli ulcer? The answer: PCR with positivity of 98 to 100% is the most specific and sensitive test for Buruli ulcer. And now the final question, question 10. What is the WHO recommendation regarding antibiotic therapy for Buruli ulcer? The answer is a combination of rifampin at 10 mg per kg plus 1 aminoglycoside, such as streptomycin at 15 mg per kg, for a total of 8 weeks. This concludes our module on Buruli ulcer. Thank you for your time.